Hi, it's Rosie Seymour here, and I'm just going to run through an overview of the webinar this afternoon. The chat room function is where chat needs to take place, and we will come to questions throughout the course of the webinar. So what are we focused on? As we've just been hearing, we're focused on the discharge requirements that issued yesterday. They are looking at how to improve transfers of care out of hospitals and into, in general, home. We're looking at how to support all of you local systems in doing this quickly and swiftly and safely. And the primary driver behind developing these requirements is to save as many lives as possible. As we know, the government is fully focused on trying to save lives through the actions that it's taking during this COVID-19 epidemic. And through these requirements, we're looking to free up at least 15,000 beds by next Friday. So I think that gives a sense of speed. We are working at speed. And so we have worked together centrally across programs and teams to produce this new set of discharge requirements, and really focused on ensuring that everyone can go home from hospital, and everyone that can does. And although this has been developed at speed, it's completely based on good practice. It uses discharge to assess and home first principles that we know systems up and down the country have shown to be really effective ways of working. And we are really keen to see that while we do have this health emergency, we are making the most of using that to push forward with the things that we need to do to provide better health and care for everybody. What we're going to do this afternoon is quickly run through the key messages from the document published yesterday. We're going to have a focus then on finance and funding flows, a focus in on continuing health care, then a consideration of the local government perspective, a focus in on care homes and hospices, and Q&A at the end. As well as the Q&A at the end, we're going to have a short Q&A after each of those different segments and pick up from the chat room 2 or 3 of the main questions. Just to reiterate, we are only going to answer questions that are related to this set of discharge requirements. We totally appreciate that there is a lot going on and a lot of pressures in the system around all sorts of things to do with COVID-19. But this focus is on hospital discharge and transfers of care of non-COVID positive people. There will be further guidance in due course that's specifically focused on COVID positive people. But for the purposes of today, this is about preparation and getting hospitals in the best place possible to get people out and home where they will be safest. As you know, we're all being advised by government to stay at home and stay safe that way, and that is no different for people who are in hospital who could be at home. So just a reminder again to stay on mute. So we've had a few issues with that. If people please, unless you're speaking, just keep yourself on mute. I've mentioned asking questions in the chat room. We know that you will discuss things in the chat room, and that is great that you're sharing information and sharing what you understand of things. We will use all of the questions and then check answers through the frequently asked questions document that will be published after this. So please make sure you look at that document when it comes out for the categorical answers on any of the questions and queries raised today. We will be recording the webinar and we will be putting it up again so that people can get access to that, and we will be sending you out the slides as soon as we can following the webinar this afternoon. We also have another 2 webinars running on Monday and Tuesday, so please do share the details with others in your system who it may be useful to listen in to a webinar next week. Ahead of that, I just wanted to focus on collaboration, joint working, and really focused on doing what's best for people in your hospitals and then out in the community. And the only other thing to highlight, which is not something that comes out very strongly from the requirements, is that this funding can also be used to help prevent people coming into hospital. So if there are people who need extra support and care in order to avoid an admission, then this funding is available to them as well. And so without further ado, I will pass over to Liz.
Good afternoon, everybody. Great to have so many people on the call. So I'm going to talk firstly, there's a lot of key messages in the guidance, but this is fundamentally about doing things differently than we do now in terms of the discharge process. There's legislation going through Parliament, I think as we speak, which will take away some of the legislative friction elements out for the period of the emergency, not permanently. So top headline key messages. Oh, and just to say, this is focused on acute trusts and community trusts, not mental health beds. So apologies, we have escalated and it will go to the mental health cell to look at what needs to happen for mental health. The legislation will affect both. So there should be no more assessments of function in hospital once someone is medically fit, as we would have known it, and we mean medically fit, i.e. they have no reason to remain in hospital. And there are criteria in Annex B that have been developed by senior doctors in NHSE that have now been past the Academy of Royal Colleges, which are being called a reason to remain. And if people don't meet those criteria, then they will, medics will be encouraged very strongly to say those people need to go home. So it's important to look at Annex B and see what they are, because they're quite different to what we discharge on currently. So discharge to assess will be the default for all patients who require assessment of their care needs. This means that the current therapy and discharge assessment in acute hospitals, so the assessments of need will be done outside of hospital. That means systems are going to need to think about how that happens and what resource they might need to shift that's currently in hospitals to outside of hospital. Then there are some pretty stringent targets in it for how quickly somebody will leave once a doctor has said that they can go. It will be 1 hour for them to leave the ward, and if necessary go to a transfer setting. It could be discharge lounges, but hospitals will have outpatients in other areas now available where it will be possible to manage even patients with dementia who in normal times we would not encourage moving, but we are not in normal times. And then they should move on from that discharge setting within 2 hours to wherever their place of, wherever they're going. There's going to be a new single coordinator who will sit within each acute trust, accountable to a named executive board lead in their own organisation to ensure accountability for delivering this change. And I'll talk a bit more about what happens when things get in the way of the change in a minute. So this is the model. It will be familiar to people already doing discharge to assess. The pathway numbers are what we think are most commonly is being used, but we're aware contextually it's different in different places. But you will have these 4 pathways available. 2 and 3 very much overlap. So what's really the bit to focus on is the numbers in this diagram, because it means 95% of people will go to home. That is not what we're doing currently. So there's going to be a real challenge about why people need to go to a 24-hour bedded setting and what would need to be different so they can go home. The figures haven't been plucked out of nowhere. They are based on a research evidence base from Oxford Brookes University, and those figures relate to every 1,000 admissions for over 65-year-olds, which makes it even more challenging. For your purposes, this didn't go in the document in the end, but this is our best attempt at what we think current discharge processes look like. Again, very different in different places. But the important bit is what we are moving on to. So you can see it's somewhat simplified. The top is what the acute sector one will look like, and the other is what the community sector one will look like. So from community hospitals, and assessments of needs, long-term needs will happen once somebody has recovered. This will, as I've already said, require a shift of resources to another place outside of hospital. And trusts will need to think about how they do that. The single coordinator post will have control they and their team, because they clearly aren't going to work 24 hours a day. There will be processes set up so that they can call on all the resources of the system to make this happen, and it won't matter who we work for. We also need to take out a fair bit of the duplication of assessment even when people get home. Everybody does not need to see a nurse and a physio and an OT and a social worker. So people will need to think about how they develop cross and interdisciplinary working. In terms of governance, acute hospitals will lead on Pathway Zero, which will include links to the voluntary sector, because in the current times, particularly people that live alone, even though they don't need care or help to get better, they may need help with shopping. We need to make sure they aren't going to become socially isolated, because if they're over 70, they will be being encouraged to self-isolate when they get home. So Pathway Zero doesn't mean absolutely nothing. The providers of community health will lead on Pathways 1 to 3, but they will be able to pull on resource from acute settings. These pathways will only be successful if NHS organisations work hand in glove with social care, the care sector and the voluntary sector. And already I had an acute trust asking if they could access the care rooms thing that's in the guidance. Acute trust just can't go and start deciding they're going to set up new pathways. This has to be done in collaboration. And actually acute trust will have enough else to focus on. They need to trust their partners to sort this. Home will be the default destination for the majority of people, and we've made available a national community bed tracker system, which a colleague will talk about later, but that now includes community hospitals. So this slide is quite important. We've had quite a lot of questions on the previous webinars about what happens if there isn't availability. The care homes won't take them, the patient won't go, the families won't take them. It will first go to this single coordinator person in every case, other than the first where the doctor's got to make the decision. And they will, if they can't resolve it, they will escalate, as in these boxes. And if it can't be escalated, if it doesn't work even at that level of escalation, it will go to the EPRR Gold Command. This will be monitored, and there's going to be daily tracking of people who are waiting and who haven't gone by the next day. The people themselves, they will be, 95% of them, as we get this right over the next few weeks, will be going home. They will not have a choice to remain in an acute hospital bed when their condition has resolved, and in Annex D there are leaflets that you can use, and we would not wish you to redo them at a local level. They are to be used as they are. They have an end bit on them for you to describe exactly what the person's going to, but we need to get these people out. If they refuse, you would escalate. And then it will become increasingly important that doctors have planned for that medically fit decision in advance, because you will have to organise TTOs, discharge summaries, transport, etc., within the 2 hours of them arriving in the discharge lounge, if that wasn't ready when they left the ward. Need to make it clear that they will see somebody either visit or most likely ring them every day, and each person will have a care coordinator. For the people going to a 24-hour facility, so a community hospital or another bed in the community, the leaflet is very clear that it's been agreed they'll go. That may not be their first choice, and they may have to move twice. The important part that makes all of this happen is the legislation that's being changed this afternoon, and the fact that the money is no longer an issue. You need to do the right things for people, and Duncan will talk about it in a minute, but the money will sort itself behind that. Things that will change for everybody are there will be no notification of assessment, notification of discharge. However, you will still need to communicate with each other, but it will be verbal, telephone calls, or any other way you think of to do it. We'll stop all meetings to agree detox data, because we'll have the discharge delays every day, but there will still be a monthly return, and we suggest that everybody moves to joint attribution, because as it's government money, it is joint. We need to spend time working out how the person can go home, and that single coordinator post will be massively influential in modelling how that can happen. And we need to think out of the box. What would need to be different so they can? The discharge process has to be activated early, and the ward or case manager will need to get the person ready for the discharge lounge. We're suggesting that where you've got the band 3-4 type discharge facilitators in wards, they can go and support wards to do that, because we think the ward staff may be quite busy. We're absolutely not suggesting that we have community in reach, because we can't have that traffic of people backwards and forwards. Other things you need to consider, which are covered in the document or other places, and some other presenters may talk about some of these, are the Mental Capacity Act, which has been covered in the guidance, and we've taken advice, and there may be issues related to that. Again, you can use escalation. Trusted assessors, but also trusted assessment, which is cross-disciplinary working. The people, receiving people in the community, will accept the referral of the person who's done it in the hospital. Homelessness is covered in the document, and we absolutely need to embed criteria-led discharge so that we're getting discharges 7 days a week at the same speed every day of the week. Ward level, this is directly from the document. The action cards piece at the bottom is we're currently working on action cards for each different professional group, which will make clear what they need to do to make this happen and what may be different for them. And then these are the reasons to remain, which I referred to at the beginning. So these will be the only, you'll have to tick these boxes, or one of them, if you're going to be deemed to require to stay in hospital. For community health services, there's other advice gone out any minute or gone to community providers about how to free up capacity. Business as usual functions of many community services will be rediverted to this. When that guidance comes out, you will be able to see what's being suggested. They will need an executive lead. They'll have to release staff from their current roles to be able to provide care and support to these people at home, along with many other ways of increasing capacity. The single point of contact will say yes. There will be no, have they got rehab potential, have they got anything else? We just get these people out. We'll need 7-day occupational therapy and physio to reduce the stay in community hospitals, to ensure flow there, and community palliative care teams will be responsible for coordinating rapid discharge to home or hospice. Equipment will be an issue. Commissioners need to be talking to your suppliers from your joint equipment services. You'll need robust satellite stores. You'll need to take out the current approval process for complex equipment. We're going to need to use the expensive equipment that reduces care packages from double ups to ones. We know from the evidence base that pays for itself anyway. You can use photographs instead of doing an access visit. You're going to have to get clever. And assistive technology, we need to use it more. This is a really good opportunity to get the change we've been trying to get. And this will significantly support dementia patients, people that live alone, and allow people to have contact with others, because the assistive technology call centres can be a part of a network that supports this. It's really important once they move out of the acute trust that they then don't silt up into the short-term facilities we've moved them on into. So there'll need to be really robust review process, both in community services and in community hospitals, to make sure that the minute these people don't need what they're having, it's reduced or ceased altogether. The single coordinator person will have oversight of that from their base within the acute trust. They clearly won't do it all, but they will be making sure that something is happening every day around every person to make the best of this resource. We're still working on some of the performance data, because some of it, we don't want to increase the burden. We're looking and discussing at how we can decrease the burden. The DTOC is still there at the moment. As far as I'm aware, so is the DPTL. But the 21 days is already falling like a stone anyway, so we're negotiating for some of that to change. But the big bit is they're going to want daily the number of patients on the discharge list and the number of patients successfully discharged from the discharge list, because they want to balance those two. And then we will want to see bed availability in community settings, looking at the capacity tracking tool. If we reduce the current variation in many things and go to the level of the best that we've got already, this is doable. So it's about just implementing the good practice we know exists, and that's what we'll monitor. Transport, please think simple first. We offer transport to everybody. Many people will organise their own. The feedback I'm getting is that many people are frightened of being in a hospital at the moment. It is a bit like Christmas Eve. Every day people want to leave hospital and many families want to take them. There will be some that don't, but let's really listen to people and what they want. For staff that work in the acute that suddenly need to go out, I trust will need to look at either ensuring they've got business insurance and repaying the cost of that if there is any. Many insurance companies do it for nothing, but also looking at leasing short-term pool cars that will allow quick transfer, particularly with equipment in, because PTS transport is not good at taking equipment because of some EU legislation I've discovered during this process. And taxis, obviously, very easy. So that was a pretty quick romp through, and if we can go to Lucy, thank you, who's been looking at the questions and will now pose some back to us.
Hi Liz, thank you. It's Lucy. So there's a huge amount of chat on the chat room this afternoon, sorry. So I'm going to ask you 3 questions. One, so there's a lot of discussion around mental health patients in the acute sector. So can I ask, how does the guidance fit for the Care Act duty to involve advocates? A lot of comments around patient choice and around public communications, whether they've gone out, whether there's a plan for any of those to go out. And then thirdly, around rehab and therapy in the community. So how do you ensure that there's access to therapy in community placements to ensure patients are accessing the right rehab facilities?
Right. So IMCAs is definitely covered because we had a long conversation about a lack of IMCAs, and that will be one of the things that need escalating. Not easy answers, but keep your discharges as simple as possible by getting them out as soon as possible would be my advice. And I think the medical criteria will mean we see patients turn around much faster on acute frailty pathways than everywhere else. So that's, I'm just looking, I shouldn't be looking at the questions coming in. Patient choice, the leaflets are clear, there is no choice. Choice policy will be part of what disappears in the legislative changes going through Parliament now. Public-facing comms, I'm assuming, will come through Boris's daily updates, and more information we'll put on the NHSEI website as this goes along. I'm looking at Rosie.
I think we certainly need to look into that and make sure that we do have a plan for supporting local systems with those codes. So please, if you do have suggestions around that, put those into the chat room and we'll pick those up through that route. And
access to therapy, we're really clear that therapists in the acute trust are going to need to reposition themselves because much of what they do won't be happening in the acute trust any longer. And just remember, most of these people don't need therapy. They need a plan and support workers. Don't overcomplicate.
Thanks, Liz. So key message there, being simple. Thanks, Lucy. Okay, we're going to move forward and I'm going to pass over to Duncan to talk us through finance and funding flows.
Hi, thanks Rosie, thanks Liz. So Duncan Watson, NHS Strategic Finance. I think the key message here is we are funding all of this new care. So if we look at the next slide, we set out what we're going to do on this. There will be a new pot of funding that will flow from CCGs, from NHS to CCGs to fund all of these new patients. So be they patients who are being discharged from hospital or patients who are in the community who would otherwise need to go into an acute setting were it not for this new care package that we're putting in place. The usual means testing requirement is suspended for those patients. So if someone is ordinarily a self-funder for social care, that's irrelevant. This funding will pay for those people also. So the key in all of this is that the finance shouldn't be a block to making all of this happen. And so we try to set up the finance system to facilitate that. The mechanics of it will be that the finance, as I say, will flow from NHS to CCGs and then will be pooled with the local authority, and then appropriate commissioners will commission from that pot, be it the local authority commissioning services or the CCGs commissioning services. The one requirement we're asking on local authorities is that they put into that pool what they would have planned to have spent on this sort of care anyway. So what was in their budgets essentially for this very specific type of care. So the sort of step up side of it and the step down care side of it. And then any additional funding that's required to fund this will come as new funding from NHS-E&I via CCGs into that pool. So just to be really clear on that, this is new funding. We're not expecting CCGs to fund this from existing funding at all. Couple of things to think about while we're doing this. So we're conscious that there's an extreme amount of pressure in the market, and lots of people are being asked to work overtime and work in difficult circumstances, and so we understand that may well be reflected in the market rates. We're expecting the commissioners to pay what the appropriate market rate is, but we recognise that what that market rate is will be different from normal times. The other thing to think about is just those what we've called here pre-existing patients. So those are patients who, before this new service came into effect, which was yesterday on March the 19th actually. So anyone from before March the 19th who was on one of these pathways, so they were being supported in the community, would be funded through whatever route was in place at that point in time. But any new patients from March the 19th who are discharged and require this level of support will be funded through this new funding. So hopefully that's clear. Just as I talked through this, I noticed one of the questions was about someone who's in community support. One of the questions in the chat rooms, if someone's having community support and they need to go into have a greater care package put in place, will this funding cover them? This funding is to cover both patients being discharged from the acute setting, to support them being discharged more quickly, but also to support people to not have to go into an acute setting. So in general, yes, this funding would support those sorts of people. If it was stopping them from having to go into an acute setting, enabling them to have a care package in place for them to remain in the community, then this new funding would support those sorts of people. So this is just how we see this working in a bit more detail. I think the thing before we get into this is just to think about quite creatively about how you do this. You should be using what you've got in place currently, and it should just be a quick flow, and then break down the organisational boundaries and just commission from this pot. There's some suggestions about how you go about that locally. You as commissioners will understand what the routes are in your locality and just use those in the way that works best for you. It needs to be pulled locally with the local authority. You've got various ways in which you can do that, including under Section 75. And then, as I said before, local authority planned expenditure. So what you ordinarily would have thought the local authority was going to spend in this space would be included within that pool, but not any additional funding. So all this new money is going to support anything over and above that, whether it be stuff that local authority would in the past have funded. It's going to support that. So work with existing contracts where that makes sense, and is usually we expect that usually to be the quickest thing to do. What we ask you to think about is whether existing contracts are financially sustainable. So in particular, many providers will be under financial strain at the moment, and so, for example, if there's a block contract in place that was thought about before there was such a huge surge in demand was envisaged, think about whether it's sustainable to still operate in quite that way, or whether you need to think more creatively about how you contract with that particular provider. On financial sustainability as well, just think about how quickly we can reimburse providers. We're conscious that cash flow and you'll be aware of this better than I, that cash flow is a significant problem for a number of providers, and it's going to be even more of a problem at the moment. So try and deal with these things as quickly as possible to support those providers. We do expect ordinary financial controls to be maintained. So invoicing, raising of purchase orders, authorising payments, and so on. But the expectation is that this is done rapidly and doesn't slow down the commencement of services. So just think about how that can happen. And then going back again to how we're going to pay for this centrally, NHS E&I will reimburse CCGs through the monthly allocation process, and we are developing at the moment how exactly that happens. There'll be some sort of claim that will need to be made, and so CCGs and local authorities, those commissioning from that pool, will need to be able to keep a check on both what you spend and on the numbers of patients, and perhaps a little bit of detail about the type of care that you're providing to those patients, so that we can then understand what that is centrally, make sure we pay you an appropriate amount, and understand what we've commissioned through CCGs and local authorities. But again, with all of this, we're not wanting this to be an administrative burden. So whatever we do decide, and we're working with various commissioner and local authority colleagues on this design, we want to be as kind of slick and easy for you to enact as possible. This funding arrangement, this enhanced discharge support packages that we're talking about, they're in place, as I say, from March the 19th through yesterday for any new patients coming through. And they will remain in place until NHS E&I or DHSC, Department of Health, say otherwise. And so you can commission these new services for these new patients with confidence that you are going to be funded for those services. There will come a point at which the kind of numbers of COVID cases have subsided, and it's appropriate to say, okay, this is the time that we need to stop this new service, this new funding arrangement, and we'll announce that and inform people of that. However, and this is really important to understand, at that point in time, whenever that is, we won't be saying, and now funding reverts to a previous model from this date. That isn't what we're trying to do at that point in time. So we recognise that there'll be lots of people at that point in time in the system who have care packages in place, who are being funded through this new approach, who might need a means test, might need a CHC assessment, and that it will take time to do those things, particularly if there's a large number of people receiving these packages. And so what we will do is make sure that the process that we put in place after we've said, look, this is the end of that process, will have enough time for those patients to be assessed by your staff, recognising that is not an overnight process by any stretch of the imagination. It will take some time to do that. We understand that. And so the funding will remain in place. So the important thing about that is that when you're putting care packages in place today, tomorrow, you can do that with confidence that we're not suddenly going to call time on this and then the funding will cease for that. But you will have time after that point, whilst these patients remain funded, and we keep funding you for these patients, to work out what those new care packages will look like. So kind of the key takeaway from all of this about finance is just ignore the finance, basically. Hopefully what we've put in place just makes it easy for you to commission and operationalise all this stuff without having to worry about the finance side of things.
Thanks, Duncan. That's really helpful. And really, a lot of chat, I think, in the chat room about what ifs and what about this. Your ending was perfect in really clarifying to everybody that this is about being blind to funding. The money is there to enable friction-free transfers of care without worrying whose responsibility it is, who's going to have to pay. We have put in place arrangements that make it easy to just get on with it. So Lucy, apart from that overarching point, what other questions?
Yes, so thank you. So there are as you said, huge number of questions around timeframes and around who this applies to. And I think most of that has actually been covered in the presentation now. Just one additional question, which I think is probably pertinent to ask. How does the guidance apply to patients already in the process to determine their funding route?
Yeah,
Do you want me to pick that up? Sorry, it's Trish here. When I come on to CHC, because I actually think that was a CHC question.
Okay, sure, yeah. And if you want to hand back to me at that point as well, more than happy to. Yeah.
Yeah.
Thank you. That's brilliant.
Okay, thanks, Lucy. Fine. Well, there you are. You've heard Trish. She's ready and waiting to get on with really going into the detail of what this means in terms of continuing healthcare. So I'll pass over to Trish now to take you through the detail.
Brilliant. Thank you very much. I'll just wait for the slides to move as well. Can I just check if clearly you can hear me? Thank you. Good afternoon, everyone. It's really important, and it's also a privilege to be on this, and also the types of questions that are being received in terms of the overall response in terms of the temporary arrangements to support the emergency response with regard to NHS continuing healthcare. We have a series of temporary arrangements that have been put in place to support these particular circumstances, and in particular with regard to NHS continuing healthcare. And in essence, those temporary arrangements cover the assessment of eligibility for individuals for NHS continuing healthcare, individual requests for review of eligibility decisions, local resolution, and independent review, and also 3 and 12-month reviews of NHS continuing healthcare packages of care. And clearly the objectives of this are to expedite the safe discharge of individuals from acute hospital beds or onto further aspects of the transfer pathway, to reduce the burden of NHS continuing healthcare assessments, both in hospital and also in community settings, because we are very clear that because of the screening checklist threshold for CHC results in 3/4 of the full assessments for NHS continuing healthcare result in people not being eligible. It is not the best use of critical staff time at this moment. And that's in order to be able to release clinical and support staff to help support the COVID-19 outbreak. The next slide takes us into what the emergency measures to be implemented for CHC during the COVID-19 period are and what the actual guidance says. It's clear as well that the guidance commenced from its date of publication yesterday. So in essence, the current legislation does not describe a specific time frame for carrying out CHC assessments of eligibility, nor does it specify a time frame for individual requests for reviews of eligibility decisions for the service to respond to those. So therefore, CHC assessments for individuals on the acute hospital discharge pathway and in community settings will not be required until the end of the COVID-19 period. So individuals can still make requests for reviews of eligibility decisions, but the time frame for responding to these by the NHS will be relaxed. This is for local resolution and for independent review. And in addition, there is an expectation that CCGs will take a proportionate view to undertaking 3 and 12-month reviews, but clearly respond appropriately to ensuring that individuals' care packages are meeting their needs, and any concerns raised are addressed as appropriate. In terms of the emergency measures to be implemented during the emergency period, clearly commissioning of end-of-life services remains vital, and clearly local systems will be putting in place those transfer arrangements into end-of-life. The fast-track pathway tool may be still used depending on local situations and circumstances. In addition, and I'm sure many CCG members on this call will breathe a sigh of relief, and I want to thank actually for the amazing work that's been done on this. The NHS Continuing Healthcare CCG assurance standards with regard of location of assessment and also 28 days will be, CCGs will not be held to account. And we want to reiterate, nor is there any expectation around timeframes for dealing with so-called appeals, individual requests for reviews of eligibility decisions. I want to reiterate that these measures are in place only for the duration of the emergency period. Clearly, it will be key, and I did see in the chat box somebody already making some comments about how we reflect, how maybe Care Tract can be changed to reflect some of these funding arrangements. It'd be really important that local systems ensure they have some method of monitoring actions taken during the COVID-19 emergency period. For example, storing up the checklist, using the checklist can be a way, one of those ways, or alternative recording systems, so that when we go back to business as usual, we can start to pick up and put the arrangements and transition arrangements back into that. There are clear implications around all of this for everyone. I'll go back into the micro detail for NHS continuing healthcare. Clearly, there will be a backlog of assessments. Clearly, there will be a backlog of requests for reviews or for appeals, both for CCGs and for NHS England. And we would need to do some work and a handling plan to support the service to get back up and running to business as usual. But it was so significant and important to flag this now, particularly as many colleagues on the call will have lived through the having to deal with 63,000 requests for previously unassessed periods of care and the impact that that had across the system. So we wanted to flag that right now and also see what we can do to support the transition back to business as usual. We wanted to flag potential financial impact around that. We also wanted to flag that there may be individual expectations that will need to be managed if these emergency funding arrangements, they are not contributing to their social care, and that we go back to business as usual and social care is means tested. But very, very importantly, we wanted to remind people, maybe this should have been our first bullet point, that those in receipt of NHS continuing healthcare are our most vulnerable in terms of their health and social care needs in our society in this crisis. And also oversight of their care packages is still really, really key in all of this. And I think that's a key message in all of this, is that it's about the frictionless funding, if you like, the liberation, and I've seen some people have said how enabling this may be, to allow health and social care staff to just focus on putting the right packages of care in place around that. Very finally then, what this means for CCGs, yes, there will still be a number of functions for CHC staff to undertake. Clearly the importance around supporting safe discharge from hospital is key. Of course, the end-of-life pathway, I think we all know that. Responding to care package and safeguarding concerns, and in particular also considering alternative models. I think this has already been alluded to by Liz around how we can support those different models and the use of technology. We are doing a series of webinars through the regional NHS continuing healthcare leads to go into much more detail about how we enable CCGs to make the right decisions in this area, in view, first of all, to support liberating staff up for the emergency, but also ensuring that we are protecting the most vulnerable people and putting right care packages in place for people. Thank you.
Thank you, Trish. That was really helpful. And I know there were a lot of questions and you were trying to respond to some of those as you were moving along. So Lucy, are there any 2 or 3 questions that we can pick up now, please?
Yes, absolutely. A couple of questions from me. So there's a lot of discussion around ensuring patients are being appropriately assessed and followed up in the community. And then sort of on the other end of the spectrum, will teams be expected to undertake 3 to 12 month reviews? There's a lot about how are we going to keep an eye on those patients in the community. And then another question about whether or not the guidance applies if a CHC patient is transferring outside of England, so to Scotland or Wales.
Thank you. We'll need to take away the question about transferring to Scotland. So I'll pick that up and see who made that. So I will take that away. Overall, if I've understood the question correctly, this is a set of guidance to enable CCGs to make the right decisions for complex care for this cohort of individuals, rather than being bound by having to do X, Y, and Z to determine which statutory authority is responsible. And in particular, I cannot stress the importance of being able to ensure that care packages are meeting individuals' needs. If you find that the 3 and 12-month timeframes for that are fit for purpose, we're not saying they should be disabled. All we're saying is make the right decisions in the right timeframes as is appropriate for making best use of staff to care for patients.
Brilliant, thank you so much. And there's just one other question that's come up a number of times in the chat room, and that's regarding the quarterly benchmarking and whether that's still due for submission.
Yes, I am actively talking with data colleagues right now about that, and in particular in view of the bigger piece around data collection, and I'm actively trying to get that resolved very, very quickly. So at the moment we haven't had a steer to stop, but I'm trying to very quickly try and get that sorted now as well and get a response.
Brilliant,
so I do apologise, I don't have a steer today, but we'll actively work to get a steer very quickly.
Okay, so we'll follow up the questions that we haven't got answers to, and they'll be in the frequently asked questions as we update those. So do keep an eye out for updates to that. I'm now going to hand over to Sarah Mitchell, who's going to talk about all of this from the perspective of local government.
Well, I want to start by echoing what Liz and Rosie have said about the importance of these discharge criteria, and that this is guidance that we've been working towards for some time recently. A lot of what's in this guidance is stuff that we've wanted to change for many years. It's reflective of good practice across the country where people have made real inroads into moving people out of hospital really quickly. And many of the things that are now not going to be causing us problems are things we've wanted to see for many years. And it will be really important to learn the lessons from this in how we might want to do things going forward. So there's always a silver lining. It probably doesn't feel it at the moment, but let's make the most of this to see how we can do things differently for the future. The most important things for local government, there is going to be, the emergency bill was published yesterday, is going to be going through for legislation next week, and there will be significant changes to the Care Act. And the most important ones are that we don't need to be doing full assessments in hospital. We need to be getting people home and assessing them once they're in their own homes, and making sure that they're safe and timely discharges, but actually making sure that 95% of the people in the hospital go home, which is where they want to be. They certainly don't want to be in an acute hospital at the moment. And for us in local government and social care, it's about empowering families and friends to support people to go home. There won't be enough care staff to be able to go out and look after everybody. So it's got to be making sure that we maximise that community capacity and get people home. There is government guidance on for residential care, supporting living and home care, and how that's affected by the current crisis. All the guidance is on the LGA website. We've got some references to it later on in the slide pack, but if you just Google LGA and COVID, all of the guidance will come up. There is money to support this, 2.9 billion. 1.9 of which is specifically, 1.6 of which, sorry, is specifically to get people out of hospital and to fund care. And therefore we're really keen to get away from some of the conversations that need to be had either with self-funders or with people themselves about moving out of hospital and the cost of care. Really important piece in this is the ethical framework that's been put in place. It's all that we would expect if you were going to be offering a strength-based approach to social care, talking about respect, reasonableness, minimising harm, inclusiveness, accountability, flexibility, proportionality, and having a community focus. And I'd urge you, particularly through principal social workers, to distribute this. It gives staff a framework within which to work and an assurance that doing things the right way, that feel right for the person and being person-centred, will be supported at this challenging time. Really clear guidance for commissioners on supporting provider resilience. It's really important people don't go out of business at this time, and we want CCGs and local authorities to commission together, maintain a reasonable market, as colleagues said earlier, and ensure that the capacity is there. And if you're not sure what good looks like for managing transfers of care, if you again go in, I'm not plugging the LGA website, but it sounds like it. If you go in and Google the LGA website and high impact changes, you will find loads of information there about how discharge works well. So the key responsibilities that are new to be putting in place is an executive lead for local authorities, making sure that you've got one person that's coordinating and leading on this on behalf of adult social care. And then where you've got multiple local authorities working in and out of an acute hospital, that there is a single lead local authority and a single working with the single point of contact for each hospital trust. We know that people get stuck in beds for long lengths of stay when their originating local authority might be further away. We obviously encourage people to work together, pool staffing to make best use of resources, and that's making sure that staff move out of the acute setting into the community to pull people out of hospital and to prevent people from going into an acute setting if they don't need to be. It's really important that you keep some presence in the hospital who can keep the social work influence on the ward rounds and the board rounds, however that works. But those staff who would have been assessing in hospital need to be going out into the community and doing those assessments out there. And we want to make sure that adult social care coordinate the work with the voluntary sector and social enterprise sector, and making sure that the NHS and voluntary sector providers work together. So specific responsibilities, as we've already said, is redeploying social work staff to community settings. And linked to that, on the right-hand side of the slide, the third bullet point is making sure that we have 7-day working for all social work staff involved in this, both in the hospital and out in the community. And if you have difficulties with how to make that happen, do ask for help from your local care and health improvement advisors in the regions, or local sector-led improvement leads who can help you with sharing the information of how people did that in other places. I can't imagine you'd have a problem at this time with willingness. It will be capacity. We want to make sure that safeguarding investigations are still done properly. There is further guidance coming out about safeguarding, and they can be done in hospital where necessary. It's about thinking where is the best place for those investigations to be done. Colleagues have talked about tracking mechanisms, and we absolutely know we need to have one care tracking mechanism in place, and people build on what they've been doing locally and what works for them. Really important message that we're suspending funding panels. Now, I know that works in some places really well, but at the moment we haven't got the time for that to be put in place. And the funding, as colleagues from the NHS have said, isn't an issue. So people need to be moving out into the community and the money will follow. We want to make sure there's increased social work provision alongside community health. So there may be staff who are not able to do what they would normally do in these circumstances and can be redeployed to support community health workers. The expectation people will be visited when they go home, make sure that that's proportionate and in response to that person's needs, so that we get the really scarce professionals who need to do particular pieces of treatment or work to the right people in the community. Making sure we've got real-time communication, Liz said earlier, let's make sure we've got phone calls. Even I've been able to get technically competent during this challenging time, so making sure everybody knows how to use all those various tools to have face-to-face conversations online, and making sure that the dynamic care capacity reporting happens. We really need to have up-to-date, timely information about the capacity out there in the community for everybody to be able to work with it. And again, the last point, but a really important point, we do not want step-down beds to get full and for people to get stuck in them. So let's make sure that social workers and OTs are making good use of those beds. Just a quick one about the voluntary sector. It's all very self-explanatory, but it is about targeting that to the practical support, settling people back home. Really important bit about keeping people emotionally well and working with the acute team, discharge teams to facilitate discharge, and making sure that everybody's working together, get that collaboration going between the voluntary sector that support the NHS and the community. Thank you.
Hi, thanks Sarah. Sorry, just taking time to unmute. So thank you very much Sarah for running through that. Lucy, any quick questions in respect of local government that Sarah can pick up?
So I'd like to say there are quite a few general questions which I think are probably best to save to the end, but nothing specific for this particular section.
Lovely.
Rosie, can I just, Rosie, sorry to come back in. I didn't mention the funding for homelessness. There is a significant funding for people who are rough sleepers, as we know that they suffer so much from respiratory difficulties. Again, please look on the website, but councils have been funded for those people.
Lovely, thanks Sarah. Okay, so I'm now going to move us on to look at care homes and hospices. So I'm going to hand over to Niall, who will then hand on to the discussion about hospices.
Hi, hello everyone. My name's Niall McDermott and I'm part of NHS England and Improvements Community Services and Ageing Well team. Okay, so I'm going to talk about some of the implications for care homes from the guidance. So firstly, I want to start with the issue of capacity tracker. So what's new and what's different? People on the call will be familiar with capacity tracker. It's a tool which care homes use supplied by Next CSU, which allows us to understand capacity in individual facilities. Well, what's new and different is in relation to the COVID-19 incident is that its reach and scope is to be expanded. So as the slide shows, we're going to see organisations to register for capacity tracker and provide data on bed capacity, all care homes, all hospices and all providers of inpatient community rehabilitation and end-of-life care. The reason for this expansion of reach and scope is to basically ensure that we have a clear national picture on a regularly refreshed basis around what capacity there is in these providers across the system. This move is not intended to replace current information systems which are used in some localities to track this type of information, but what we're going to ask you to do is to continue using those, but also in parallel continue to use capacity tracker just for the period of the COVID-19 outbreak only. Data to be collected is numbers of beds, numbers of vacancies, and then some business continuity type information. So numbers of residents showing symptoms of COVID-19 or having COVID-19, and some basic workforce level information. As I've said, this information will be included in national daily situation reporting, so it's important that this information is updated as close to real time as possible. And that will help local systems in particular understand where capacity is in their area and will really support the wider goals of discharge planning. This new functionality will go live next Monday, so Monday the 23rd of March, and we absolutely recognise, and I'll come on to this in a moment, that there's a big ask for organisations who aren't using capacity tracker at the moment to sign up and use it, and we're hopeful that all organisations listed above will be using capacity tracker by the 1st of April. So what action is required to make this happen? Well, CG have got an important responsibility in this domain, and we're going to ask them to nominate some system champions to help providers register and supply the information to capacity tracker that they need to. CCGs will be asked to nominate the assistant champions to next CSU directs using the contact details there. So the role of assistant champions is important because providers can't just register for capacity tracker and input data. They have to be approved first, so the assistant champions will act as approvers. Once providers are approved, they nominate approvers within their own organisations themselves to actually submit data. Registrations capacity tracker can be done through the link that's on the screen. There's obviously a really big communications challenge at the moment with regards to this. This is new for many providers, and we absolutely recognise that. At the moment, a considerable amount of work's going on to support how we can help providers get used to the system in the form of guidance, video tutorials, user guides and walkthroughs. And they will be accessible early next week from the above link to the next CSU website. In addition, a supportive call centre is also being mobilised. We're hopeful that will be up and running Monday, Tuesday next week, and they too will provide as much help as possible and guidance, so that between the period of 23rd of March and 1st of April, we can get as many people as possible signed up to this system and help them submit data, which is really going to help in responding to the incident. Okay, in terms of some kind of broader issues that flow from the guidance, repatriation and transfer of patients is clearly an important issue. I want to use this opportunity just to signpost you to some really clear and practical guidance that's already been issued in relation to this. So PHE have published guidance to care homes during the COVID-19 incident, which provides some really practical and tangible advice for care homes on how to respond to patients who either have COVID-19 or maybe suspect of doing so. And equally, there's some wider guidance on managing elderly and vulnerable individuals in these settings also available. PPE is also a broader issue, and I can see from the chat box and from previous sessions and of course across the media the scale of concern about this. So we've been working really hard with our partners to try and ensure that PPE supplies reach the right places. Department of Health and Social Care have clearly indicated that there's no prioritisation here, so it's not NHS first and then other settings later. There is equal priority on this issue. They've been working initially over the last few days to try and get some stocks out to providers, and every care home and home care provider will be receiving at least 300 face masks by the end of Tuesday next week. There's then also clearly the ongoing issue of business as usual and resilience. So DHSC and colleagues have set up a national supply distribution line, and the contact details are on the slide there. Now, because there is so much concern about this, colleagues on the line and elsewhere understandably will be trying to raise issues through whatever routes they feel appropriate at any one time to try and sort out the issues that they're experiencing. Can I please encourage colleagues though, however, to try and engage with the supply distribution line. That'll make sure we have a clear picture of what's going on in one place so that we can respond appropriately to the concerns that are being raised. In addition, there's a whole heap of work being done in terms of trying to broaden our access to NHS mail to care home settings, and some guidance on that is in train, some really practical guidance around how you would set up NHS mail if you're a first-time user. This functionality is important because it doesn't just include email. So many of you will have seen the announcement recently by Microsoft that they're making their Teams platform available free of charge for the period of the incident. I'm just thinking back to what colleagues have said before about the importance of picking up the phone and dealing with each other face to face. Teams' video calling functionality is really important around that and will make a big difference. We're working really closely with our partners in NHS Digital and NHSX on all of this, and the link to the NHS Mail portal is there, and that'll keep you up to date with all the latest developments. I think there'll be time for some questions more broadly at the end, but I'm going to pass over to end-of-life care colleagues now.
Hello, I'm Marie Hancock. I'm speaking on behalf of Sue Bottomley. Can you hear me okay?
Loud and clear, Marie.
So in relation to planning hospital discharge for patients with palliative and end-of-life care, the same principles apply as was detailed in Pathway 1 earlier, where 45% of the population could be discharged if they had ongoing support from health and social care. What we are suggesting is that we need a coordinated approach, and colleagues early on in the webinar talked about safe management and having a single coordinator for discharging patients. We'd also like to see patients having a personalised care and support plan which fully contains all the facts that are required for their care, including facilitating rapid discharge and continuation community services and medications, and for those teams, discharge and community services to liaise with each other. Patients who have palliative and end-of-life care needs will need to be identified by the hospital team's coordinated colleagues, and people spoke about that earlier, with support from the community teams. If patients require specialist palliative and end-of-life care support from the hospital teams, if there is capacity, then that would be great if that can happen. However, we are moving towards this rapid discharge, and if there isn't time to mobilise the hospital specialist palliative care team, this should not stop or delay that early discharge. The majority of people who are accessing hospices in terms of eligibility should have a personalised care and support plan as well. So what help do we need from each other? We need hospices to communicate with the hospital and vice versa. We'd like the bed tracker to be in use by the 1st of April, and colleagues mentioned this earlier. We'd like hospices to work on bed capacity, please, in terms of making this real time. For hospices to be willing to accept patients, please, on a 7-day a week to accept admissions. And for hospices, we really need to consider the extra activities they do, and can they free up some of that to allow emergency capacity if, as and when it's required. And this will help with hospital workforce planning as well. So what have we been working on? We've been developing some guidance around treatment escalation plans. We'd like to see good communication between the hospices and hospitals regarding like medication, resource status, and any treatment and escalation plans. What we will offer is we will offer support with resources to ensure that hospices can maximise their capacity. Our support offer is in 4 tranches. So like I said, we've been developing the guidance. We've been working with the supply chain in terms of PPE, and also doing some work around syringe drivers. So remembering there have been issues in the past with the T34 version 3 and the battery issue. What we'd like to see is if there are any additional pumps, syringe drivers available, that that we're trying to maximise the use of those. But also what we're looking at is whether there's any possibility of moving over to more subcut stroke PRN use of medications, but recognising this is not ideal, but that might be need to be used in some circumstances. In terms of testing, we'd like to see hospice staff given the same guides as NHS staff in terms of COVID-19 testing for their staff. We see them as being in the essential category as well. And then this links with the essential workers list, which has been developed, and we've been working with Hospice UK and Together for Short Lives on this list. Finally, in terms of financial support, our colleagues have already mentioned that we're moving away from PBR and tariff and more to assumed block contracts. But Duncan could explain more about that if there are any specific questions. What we'd really like to do is move to support that speedier process of getting the money out to the system. And finally, we have an email address that's on there, a specific COVID email address, if there are any questions that you would like to ask the national team.
Thanks, Marie. Okay, Lucy, any of the 2 or 3 top points from the chat room?
So specifically relating to care homes, no, but there are, like I said, some general questions that I would like to ask at the end.
Okay, so nothing specific on care homes and hospice at this point. Okay, that's fine. Lovely. So we are now at the end of the webinar in terms of presentations to you. And Lucy is now going to run through some of the general questions that have come up through the chat room.
So I guess there are sort of 4 themes that seem to have come out, so I'll cover each one. So the first is around comms and engagement. There's a huge amount of discussion about comms and engagement, both in terms of externally facing communications and engagement amongst care providers, support from unions, and the need for them to sort of back up this guidance and help. And a lot of comments around NHS Mail and ensuring that everyone who needs to be is on NHS Mail. So I don't know if there's anything you'd like to add to that.
Thanks, Lucy. In terms of comms and engagement, and specifically with provider sector and so on, we have clearly got more to do, and we're very keen to make sure that we're doing that. And we're very happy for people to suggest particular sectors that they think we need to focus on in terms of engagement next week, so that we can take that forward. So we'll take on board the comments in the chat room around that. Niall, I was going to just come to you in terms of NHS Mail.
Yeah, so thank you. So as I say, guidance is literally on its way. So drafts are prepared, etc. And then just linking to the previous point, we've got to, with your help, make sure that we can work out with a way in which we disseminate this as widely as possible. Pretty confident that's in place, but any ideas, suggestions, thoughts, gratefully received.
Lovely, thanks, Niall. So put those into the chat room, please.
And there are a number of ideas coming out of the chat room, so we'll look through we'll take the transcripts of the chat and we will analyse that and pull out everything that's useful and helpful. So thank you to everyone for your comments. So the second theme that seems to be coming out, there's been a huge amount of discussion about ensuring there's sufficient capacity within the community sector and the voluntary sector. And a couple of specific questions I wanted to ask you. So one, has there been discussion with the CQC to enable relaxation of registration scope where needed in this crisis period? And secondly, can grants be paid out for COVID money to the voluntary sector to undertake some of this work?
Okay, so in terms of capacity, and then the specific question about the voluntary community sector, yes, absolutely. This is about freeing up what we can to ensure that local authorities and CCGs are working together to make the best use of the capacity that is available. That is both through the normal provider route, but also through relationships with voluntary community sector. A lot of those relationships are in place, and it will be about working collaboratively with the voluntary community sector to put arrangements in place to try and expand the support that they can give, and Sarah Mitchell covered a little bit of that when she was talking, and there is more available, and we are happy to sort of do more and work with the voluntary community sector over the next week or so to try and make sure that they have clear lines and communications around this. Liz, in terms of CQC?
There has been some relaxation. I'm not sure I can completely describe what Niall or Trish, but there are relaxations there, and then definitely not doing any more visits. But in terms of trusted assessor, for instance, we've involved CQC previously and recently in what that looks like, and they will support care homes, but that's right.
We'll come back specifically on the registrations point and put the response in the frequently asked questions once we've clarified.
Rosie, can I just chip in? If you want to know about CQC, Kate Torona is doing a blog and it's really well received, so worth having a look at that, colleagues.
Okay, thanks, Sarah.
There's quite a lot of questions that seem to me linked to what the current regulation is. We're in different times, and there's an element of do the right thing first, so not completely break the rules, but do the right thing. The money will flow behind it, and this is something I saw yesterday, but the government is putting together an insurance pot to provide a bigger vicarious liability behind to support people doing it differently. And I think this is not going to be perfect. It's just going to have to be good enough. And if we try and keep everything as perfect as it is now, we're in extreme times, and other people will suffer because we've got to be brave, basically, and take a bit of a courage pill.
Thank you. Thanks, Liz. Lucy, any final questions from you?
So the two other themes I'll say around mental health needs. There's a lot of conversation around mental health needs, and the final one was around roles and responsibilities. And there weren't any specific questions around roles and responsibilities, but as a theme, I think it's one of those things that will be picked up in the asked questions, because people are talking about what's the roles and responsibilities of different organisations and different groups of around the mental health needs. There's a question I believe you've answered already, but it has come up a number of times, so I'd like to ask it again, and that is, does the guidance apply to S117 patients, especially those currently in acute hospital beds?
None of us sitting in this room are mental health experts, but my understanding is most 117 patients are in acute mental health beds, and this guidance doesn't cover acute mental health beds. The legislative changes around the notification process will, but we've escalated a number of times. And my view is all these questions about the little groups, as you discharge the bulk of patients who will be simpler to do without the friction, the ones that are left will get escalated up through the EPRR route, and the centre will become aware of what it hasn't thought about, basically, and they'll have to make a decision at that point.
But obviously we will take back the feedback from this webinar and the previous one, and be clear that there are a lot of people raising this issue, and we need to make sure that we come back with some clear guidance for local systems in respect of that. The other point to make was that Liz covered was the action cards that are coming. So those action cards will help in terms of those issues of roles and responsibilities. But I think, as Liz has said, perfect can be the enemy of the good, and with roles and responsibilities, I think we're just anxious for you to make sure you are getting the right people within your system, doing the right things and pulling together the right resources. So if that isn't quite what is described in the guidance, but it's the right thing for your local system, we would encourage you to get on with it, as long as accountability is clear and as long as the governance is clear. Just get on and do what you need to do to provide friction-free transfers of care in a world where funding, source and responsibility is blind. These are really difficult times, but there are also opportunities here to show what can be done when we don't have some of the sort of usual processes and issues about shifting responsibility around the system. You're all responsible. You're all responsible for getting people out as soon as you can in a circumstance that is pretty unprecedented. So while it is a challenge, we would encourage you to also think about, for the future, on the other side of this challenge, the things that have really worked for your system and the things you'd like to keep in normal business times, so that we can try and at least embed the really good things that have happened. So I was just going to end there in terms of questions and in terms of the input from us. As I said, we will be updating and then publishing frequently asked questions from the webinars, and we'll be publishing those shortly. We'll also be uploading a recording of the webinar and sending slides to those of you who've registered for these webinars. There are 2 more webinars next week, one on Monday and one on Tuesday, that are a repeat of content. So if you do think that there are people that would then benefit from listening to the webinars and being on the chat room, then please do forward those on. The other point to make is that we will be setting up some virtual clinics. So if you need more in-depth support, you've got some detailed questions that you want to run through as a local system, we will be setting those up, and details of those clinics will be available shortly. And in terms of where to go right now, the Better Care Exchange now has a dedicated page and forum for the discharge requirements, and if you have particular support requests that you need looked at right now, email the Better Care support inbox. As I said, the slides are being circulated and the details for doing that will be on those. There's a couple of slides as well with some useful links that will have the requirements, things that have been talked about on this webinar in terms of the bill and the ethical framework and the guidance that Sarah referenced. So those will be in the slides that are coming round to you shortly. So I would just like to thank you all for your patience, for registering onto this webinar so promptly with so little notice, and for bearing with us. I know there's been a bit of background noise here and there, but hopefully that hasn't stopped you from hearing the key things that you needed to hear. So thank you all very much for your participation this afternoon.